Okay, just give me the thumbs up and we're working on sound. We're good? All right. Making sure everybody online can hear us. We're going to call the Cook County Health and Hospital System Finance Committee meeting to order. Will the secretary please call the roll?
Director Green? Present. Director Harrington?
Present.
Director Laurie?
Present.
Director Robinson?
Present.
And Chair Ryder.
Ryder is here. Just want to very quickly acknowledge for those who are regularly in attendance, you'll see that our normal soundboard operator, Sam Gergone, is not here. His father passed away. The funeral was today. So keep Sam and his family in your thoughts, but we have some other folks from IDW Local 134 jumping in to help. Sam's backup isn't here today. I'm guessing he's at the funeral as well.
I think he's on vacation.
Oh,
They weren't expected. It was unexpected.
Yeah, unexpected. Yeah. So, irregardless, people always jump in to help. So we appreciate that here at the hospital system and the labor movement. I think that we have all the members of the committee here, so we don't have to worry about anybody participating remotely. The next regular meeting of the Finance Committee is scheduled for Thursday, December 11th at 10 a.m. Madam Secretary, do we have anyone here to provide in-person testimony?
We did not receive any registrations nor any written testimony.
Okay, and no virtual testimony. Do we do virtual testimony anymore?
Yes, we do.
Okay, I couldn't remember. All right. Is there any members of the public present here who didn't previously register that would like to offer any testimony? Okay, hearing none. Going to move on to the first action item, the October 16, 2025 Finance Committee meeting minutes. These were approved at the October board meeting, but are being presented for the committee's review and discussion, if necessary, and any corrections that need to be made to the minutes. Any corrections? Hearing none. Is there a motion to accept item 3A, the October 16th Finance Committee meeting minutes?
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none. All those in favor signify by saying aye.
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 Opposed? The ayes have it. All right, we're going to go to items under the Chief Procurement Officer. We have a total of 20. Is that right, Charles? I thought we were at 17. Okay, Charles is going to explain that. Last time I checked it was...
And Chair Ryder, for the record, we have Chair Garza remotely connected. We do not need a motion. Just wanted to state for the record.
Hi, Ralph.
Hey, Bob.
So,
good morning.
Charles?
Yeah.
Let's, you got the pilot, so.
Good morning, Charles Jones, Chief Procurement Officer for CCH. We have before you today for review 20 items. 17 of those are our regular contracts procurement. 3 of those are expenditure items. Of the 17 that are normal items that require responsive letters from the Office Bureau Business Enterprise Development, we have 12 back and 5 are in process.
All right. I'm sure you'll explain those expenditure items when we get to them, or someone will.
Executive sponsor.
Okay. All right.
Thank you.
So first up, we have the Cook County Department of Public Health, Dr. Joshi, our Chief Operating Officer, and Marley Hendricks, the CCH Director of Public Health Administration.
Good morning. Yes, the first item before you is a request to increase contract for the Bright Light Radiology, which is a service to provide breast imaging services. The request is to extend the contract for an additional 49,000, or I should say, not to exceed $49,582 through fiscal 2026.
Any questions for Marley? Hearing none, we'll move on to, thank you, Marley. We'll move on to items 2 and 3, Health Plan Services, which are being presented by Aaron Gleaner, Chief Administrative Officer, Health Plan Services. Good morning, Aaron.
Good morning, Chair and Directors. Good morning. This first item before you is for vendor Centauri for a one-year extension. They provide application assistance for individuals within our health plan that we are assisting them with applying for SSI and SSDI. Next contract is for administrative services with Evolent Health. This is a 3-year contract. This does not actually relate to county care, but relates to a at-risk agreement we have with Blue Cross Blue Shield for our Cook Medical Group entity. Total amount is $6 million.
Any questions for Aaron on either of these two items? Hearing none, we're going to move to items 4 through 8, being presented by Dr. Daniel McCormick, our Executive Chief Clinical Officer.
Good morning. Good morning. I have 5 items for your consideration today. The first is Department of Surgery, extended increase contract with Steris, a total of $1,150,000. Let me start with this. All right. We're going to present this in a different order. This is the Department of Medicine. My error. It's Dr. Peter Hart, Department of Medicine. This is a product service for peritoneal dialysis to extend and increase the contract through 12/31/27 for a total of $5,814,064. And this vendor provides peritoneal dialysis for the home dialysis program in end-stage renal disease patients. The next is the Department of Surgery, and this is with extend and increase the contract with Steris, instrument management services. This is a total of $1,150,000 through April 30th of 2026, and Steris continues to provide the maintenance for scope repair related services for surgical instruments at both Stroger and Provident Hospitals. Next is, again, the Department of Surgery with executed contract with Hanger Clinic, which is supplies for orthotics and prosthetics. All right. They gave it to me in different order. This is given to me in the wrong order, so let me correct this. The order is, this is for Dr. Keene, Department of Surgery. This is for execute a contract with W.L. Gore, intravascular grafts and supplies for a total of $1,500,000. This goes through November 30th of 2028, and this is provision of polyester intravascular grafts, hernia patches, and accessories.
The soundtrack's my life.
All right, next, Department of Surgery. This is for execute contract supplies with Hanger Clinic. This is for $1,050,000. This goes through November 30th of 2028, and this is a sole source vendor to provide custom orthotic supplies for CCH physical and occupational therapy departments, as well as Cermak Health Services. And then lastly, Director of the Med Staff Office. This is services to execute a contract with HealthStream. This is for $356,200 through November 30th of 2028. And this request automated software for physician credentialing and verification for the med staff office.
Any questions? All right, thank you.
Thank you.
We're now going to move to request number 9 through 12 under finance. It's my understanding that the first one is request number 9 is being withdrawn. So Dr. McKay just told me. So we'll go to request number 10.
Good morning, Scott Anderley, Director of Managed Care for Cook County Health. System Innovators, payment processing software vendor. This vendor provides payment processing software, i.e. credit cards, for patient payments. This request is to allow us to operate while we implement a replacement service from a recently rewarded RFP. The vendor is Flywire. This request is to extend and increase the contract in the amount not to exceed $10,134.48 for a period of 12 months from December 1st, 2025 through 11/30/2026. Next vendor is EnableComp. This vendor provides services to file healthcare liens, appear at court proceedings, to bill and to collect on workman's comp and liability accounts. These services were previously provided by the State Attorney's Office. However, they approved to realign to an industry leader. This request is to extend and increase the contract in an amount not to exceed $500,000 for a period of 12 months from October 1st, 2025 through September 30th, 2026. And then the third one is Optum 360 LLC. This is a charge master review software service. This vendor provides software to assist in maintaining our charge master to ensure compliance with Medicare requirements. This request is to amend, extend, and increase the contract in an amount not to exceed $82,164.89 for a period of 12 months from June 21st, 2025 through June 20th, 2026.
All right. Do we have any questions? Hearing none, thank you. We're now going to move on to request number 13, Finance and Health Information Systems, being presented by our Chief Nursing Information Officer, Benjamin Lawton.
Morning. Morning. This is a request for a one-year amendment, extension, and increase with Atos Digital Health Solutions, formerly known as Breakaway Group. They provide content and delivery of computer-based modules to train our nursing, revenue cycle, and physician teams to maximize the use of our electronic health record. The vendor allows us to standardize how our teams learn to use the EHR. It reduces time spent in classroom, improves consistency in training and documentation, and it reduces our onboarding time.
Any questions? Hearing none, we're going to now go, thank you. We're going to now go to request number 4 through 16. Craig Williams, our Executive Chief Operating Officer. And you're on the agenda here twice, so I'm wondering if we can also knock out 19 and 20.
I'm going to go straight. I'll do...
well, you're going to do them all.
Kathy, too.
All right. It's not what it says on my...
I had a late change to the agenda. I'm sorry about that.
I was supposed to write that on your notes, and I apologize.
I'm going to blame that.
I didn't want Adam Weber to go because he's dressed so nicely. I didn't want him to outshine me, so I decided to do it myself. First one I have is Anchor Mechanical, which is an extended contract with no fiscal impact. 12-month contract period starting 8/9/25 through 8/8/26, and this is through our capital improvement plan. And this is continued to provide HVAC and mechanical repair and renovation services for Providence. Premier Glass Services, extended increased contract for $82,375. 6-month contract period, 12/1/25 through 5/31/26. This extension or increase is specifically to deal with In the emergency department along Ogden, we have clear glass, and people who are walking by can see directly into our trauma bays. And that's obviously a privacy concern as well as a risk for those patients and that staff. So we're adding a window coating that will allow patients to see out but not allow a view from the outside in. This is what this contract is for. Garrett Callahan Corporation is a GPO vendor, and it's an execute contract for $1,369,762. It's a 36-month contract, 1/1/26 to 12/31/28. And this is for water treatment services on the boilers and chillers at Stroger and Providence. They're also doing a supplemental disinfection program to address potential Legionella issues at Stroger and Providence, and include a water management program with testing to confirm standards there. We'd actually released this for RFP twice, and there were no qualified vendors, so we were able to create this contract with one of our GPO vendors.
So just out of curiosity, what are they going to be doing? Are they just doing the testing, or?
Yeah, they'll be doing.
I'm going to ask Alejandro Corona, who's our Chief Facilities Officer, to come up and address that question.
Good morning. We're providing services for pre-treatment of water for our steam boilers, closed loops, testing of the cooling towers for Legionella, in various areas of the plant operations.
On this water treatment is a constant process. We're not talking about a constant process. We're talking about making sure that we have everything set up properly.
It's a two-part contract. So one relates to the back of house equipment, which is a closed system, correct? In these closed systems, we treat the water. We call it pre-treatment, acting as scavengers, making sure there's not minerals in the water, all the other stuff to make sure that we provide clean, super clean steam to the systems. On the other part of the contract, we're going to be doing the point of use testing for Legionella, making sure that we have the right program for disinfections and all other things.
Who's responsible for the day-to-day management of our water treatment system?
That would be
building engineers? Is it plumbers?
It's the operating engineers and the plumbers, yes.
Okay.
So John Bench.
Okay.
It's him through me.
Okay.
Water treatment for drinking versus Legionnaires is very different.
Correct. So we have, when we do Legionella testing, we're testing the points of use, meaning the sinks, the showers. We have ice machines. So the ice machines obviously have the self-contained Nephro filter, which is what we use normally at home in our refrigerators and those appliances. But our task is to make sure that the domestic cold water and hot water that we provide throughout the systems, that we are has enough chlorine in the systems, that there is no stagnation of water, therefore creating bacteria growth.
You're making sure that the water coming in and going out, the service delivery is good, and then the service delivery, being the faucets, the machines, all the outputs are also not containing residual contamination from the piping and whatnot.
Yeah.
You said the key words to say that you are actually doing something about Legionnaires. I have a water background, so I understand it quite well.
Yeah, prevention. That's what we're doing.
Okay, great. Thank you.
Thank you, Alejandro. Next one is for Donica. It's for Priority Healthcare. This is an execute contract for $625,000. And this is to supply internal uterine devices, IUDs, to our family planning clinic. And this is a sole source because this is the only U.S.-based distributor of this device. So I also have 3 expenditure requests. The first one is for Favorite Healthcare Staffing. It's an $83,725 expenditure request. This is under a prior contract which is expired. There is outstanding invoices that date back to 1/22 that were for agency cardiac sonographers. that had been submitted to the incorrect department, and so by the time they got tracked through the right departments, the contract had already closed, so we're asking to have these paid. The next one is for Anderson Elevator. It's a $584,498 expenditure request. So this contract was terminated in 2025 due to the performance of the contractor. We had piggybacked on a countywide contract, and frankly, we were disappointed around the kind of scope in the contract as well as the 24/7 nature of healthcare that this vendor understood and could comply with. We do have an active RFP for the elevator services for CCH, and it's close to wrapping up to address the long-term needs of the system. These invoices were incurred for emergency elevator repairs that were not covered under the contract, which kind of speaks to the overall scope and everything else.
Since we're talking about elevators, and on this building, this building was designed, built, and opened before you got here. And there's one elevator bank that has glass separating it for back, what I would call back of house and then front of house, right? If you had to design this building again, would you put another elevator bank in it? I mean, I come here on a random basis. I just think that I sometimes feel like there's not enough ingress, because when an elevator goes down in that elevator bank, it gets, and it happens, right? And you want to be able to shut down elevators, so, because I know a lot of people who've been in elevators who lost stability, so.
Yeah, I mean, our issue really has been around the reliability of the elevators overall, I think, and honestly, I can't explain it in this building because it's a fairly new building. I think that
maybe that's the issue. Maybe we build with the expectation that we wouldn't have.
And I'd say on average, since I've been here, we've probably had at least one of the 8 elevators down at a given time, and so that creates a significant decrease in performance. The other thing we see, certainly on the employee side, is that there's a lack of understanding that you have to, badge in. And so people push the buttons and the elevator doesn't go anywhere, and they think they're stuck. And so we end up having a lot of outages, and we've been trying to do a lot of signage work and other things. But ultimately, I would say, not necessarily in this building, but throughout the system, we're doing an elevator modernization as part of our capital improvement plan, which really should significantly improve the reliability of and safety of our elevators.
Because I feel like when someone was looking at this building and they put that elevator bank in, they were looking at what the population of the building would be at any given time, but they weren't thinking about that's now divided in half because of the glass wall.
Yeah.
So it creates a lot of unevenness coming up from the ground floor.
Yeah.
So.
Yep.
Yeah.
Good observation. Okay, the last one is for Hillfire. It's an expenditure request for $67,140. This was invoices incurred in 24 and 25. We contracted this service for testing and inspection of our extinguishers, sprinkler systems, and kitchen hoods. The additional spend that we're asking for here was for increased scope in the original contract, like when we opened Bronzeville, as well as equipment that was not part of the original contract. We completed an RFP for the testing and inspection of the fire extinguisher, sprinkler, and hoods recently, and that was awarded to Johnson Controls. So this is just to close out old invoices under that contract.
All right. Any questions for Craig? Anyone else have any observations on elevators?
I learned a lot.
It's just struck me because I'm guessing that when you have an 8 elevator bank, one goes down, you have 7 other options. But really what we have is, depending on usage, you have 1 elevator down. And if you're the public or if you're staff, you have 3 other options. And in a hospital, even on the professional building side, we're still moving people in a way that's different than you would see in a commercial office building.
Yeah. Thank you.
Thank you. All right. Is there a motion to approve item 4A, contracts, procurement items containing request number 1 through 20, subject to completion of review by contract compliance.
So moved.
Motion's been made, is there a second?
Second.
Motion's been
There's a
made.
question.
Eddie?
With the exception of request item number 9, which was
With-
withdrawn.
With the, can we, the maker of the motion, which, we're gonna,
Withdraw the second.
I
Withdraw
move,
the motion.
I withdraw the previous motion. I now move to
is
approve.
the second, and the second is withdrawn. Is there a motion to approve item 4A, contracts, procurement items containing requests, request number 1 through 20, excluding, request number 9, which has been withdrawn, subject to completion of review by contract compliance?
So moved.
Motion's made, is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right. Continuing with Charles, fiscal, I believe what's next on the agenda is the fiscal year 2025 quarter 3 report of contracts executed under CEO authority. Contracts with less than $150,000.
Yes, thank you. So before you, you have 16 items presented. All 16 items are responsive for MWBE contract compliance. 12 of the 16 are with our GPO vendor, our group procurement organization. 11 of those 16 are for capital equipment that we purchased as we spent down our capital budget for FY 2025. So going through a couple of the higher dollar ones, over $100,000, we have Carestream Health, Inc., Dry Revolution, or mobile X-ray system for $135,000. Evidence Scientific, we bought microscopes for anatomic pathology at Providence, $146,000. Olympic American, we bought bronchoscopes and accessories, $125,000. Skytron, prep and package stations, Mayo Sands, trash hampers, stirrups, full pad tables, cabinets, and for Stroger, $141,000. Strucker Sales LLC, we bought patient transport carts and bedside tables, overbed tables and recliners, $128,000. And then another one for Strucker, we bought, we did ProCare plan maintenance, preventative maintenance with equipment in the neuroscience department, $149,000. Any questions on the particular contracts under the CEO's authority?
Any questions for Charles?
Thank you.
All right. A report of emergency purchases.
The first one before you present on October 23rd. This is for the vendor to provide maternal fetal medicine physician services on behalf of the Department of Maternal Fetal Medicine with Advocate Health and Hospital Corporation, 24-month agreement for not to exceed $950,000.
Any questions for Charles on emergency purchases? All right, hearing none. Thank you, Charles.
All right, we have 4.
Oh, I'm sorry.
No, wait a minute.
I skipped.
Right.
The other 3.
Thank you, sir. I'll be out of here in a second. CMS Medical Staffing, Inc., that was a 6-month renewal option contract and extend, the increase and extend that contract for vendor to continue provision of hematology oncology locum tenens on behalf of the Department of Medicine. 6 months, $1.56 million from 9/23/2025 to 3/31/2026.
I'm always looking to get to the agency reduction plan, so.
No worries. Then on October 23rd, again, a request for the vendor to provide supplies for the Department of OBGYN Administration. This is Medgani Products, Inc., 12-month contract, $32,500. And the final one was submitted on October 28th. That's also a contract to extend and increase with Relay Health Pharmacy. Then it will continue to provide software support for pharmacy claims management services on behalf of our system-wide pharmacy department from 11/1/2025 to 10/31/2026 in the amount of $80,000. And the emergency purchase. Any questions?
Any questions? All right, thanks, Charles.
Thank you very much.
Next up on the agenda is our grant award related items. Pam, Sarah, our Chief Financial Officer, will be presenting those.
Good morning, Chair, Directors. We have 5 grants before you today, 1 award, 1 extend, 2 increases, and 1 renewal, totaling $814,986. If there's any questions, we can ask the executive sponsors to speak to them.
Are there any questions? Hearing none, is there a motion to receive and file item 5A, the grant award related items?
So moved.
Motion is made, is there a second?
Second.
Motion is made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? You guys have it. All right, let's do the September financials.
All right. On an accrual basis, the interim financials through
By the way, it's been a long time since I've seen the word unfavorable.
Yeah.
Read on so many different places on our slides here.
Yes, unfortunately. So again, ended September 94.5 million unfavorable to budget on an accrual basis and 33.7 million unfavorable on a cash basis. The reasons have remained the same all year. On the revenue side, we're favorable in total due to the capitation revenue from county care being higher related to the higher than budgeted membership. But on the expense side, we were also worse or higher than budget because of the claims expense that goes along with that higher membership. So we'll talk more about that as we go through the slides. Next slide.
Those aren't necessarily bad. Those numbers
Well,
can offset each other, right?
To a degree, and we're going to talk about that today. Yep, next slide. So here's the financial statement, just calling your attention to the total revenue line, as I just mentioned, 101 million in total, greater than budget. However, on the hospital and clinic side, the net patient service revenue, 200 million under budget, while the county care revenue is 291 million over budget. Total expenses, 192 million worse than budget, which brings us to our bottom line, or variance of 94.5 million worse than budget. So next slide, Debbie. So here I do want to talk about just a second what Chair Ryder was alluding to. So again, starting on the left there, net patient service revenue, 214.5 million worse than budget. Net patient service revenue, again, is the revenues from the hospital and clinic side of the business. But then you see a bunch of green bars, and ignoring the county care capitation green bar, the other green bars, the 99 million savings we've achieved in salaries and benefits and 92 million in purchase services, those two, the 99 and the 92, basically offset the 214 million, right, that the hospital and clinics are behind budget. However, when you look at the county care capitation, 291 million better than budget or more than budget, but their claims expense, the big red bar to the right, 375 million worse than budget, right? So those two numbers do not offset each other, and county care year to date is over 82 million in the hole. Aaron, when we get to the county care slide, I'm going to invite him up to speak to some of the things they're doing to try to drive the cost down, but the claims expense continues to be a driver of their losses. Next slide. So on the hospital, going back to the hospital and clinic side, volumes continue to lag behind budget. We are closing that gap, though, on the revenue side through other savings initiatives that we implemented earlier this year. Next slide, Debbie. The volumes, again, over time haven't changed significantly. They peaked at the height of the pandemic when we had the expansion of coverage and have come down slightly, not significantly, since then. Next slide, Debbie. Our payer mix has drastically changed, as we've talked about all year. The Medicaid, again, reaching its peak during the pandemic with the expansion to the health benefits for immigrant adults and seniors. And then with the end of the pandemic and resumption of redetermination process for people on Medicaid, we've seen it tick down and uncompensated go back up. Next slide. RevCycle continues to work on their key performance indicators. Their AR days look good. Cash collections in the yellow, but have been pretty much getting all the indicators getting back in line over the course of the year. Next slide. Same with denials. They continue to hit on all their benchmarks related to denials, being less than 2% of cash collections, decreasing the reasons year over year, and the total dollar amount. Next slide. Charity and public program expenditures. So here, the traditional charity care and other uncompensated, which is the bad debt, is significantly greater than we budgeted for this year. Again, going back to the resumption of redetermination and the shift we've seen from Medicaid back over to charity. Next slide. So that makes our savings initiatives, as we mentioned, mid-year we were projecting a pretty significant budget gap, and so there were a 10% reduction plan, as well as several revenue cycle and renegotiation of contracts, and of course, the agency reduction plan that is helping us close that gap. Next slide. Which brings us again back to county care, and Erin, if you want to come up. County care is, again, $85.7 million unfavorable variance to their budget. That's being driven by the higher medical loss ratio and the underfunding for their high-cost drugs and NICU cases, as we talked about last month. But I've invited Erin to come up and speak about, it's probably too late to close the gap for this year, but they are working on a lot of initiatives to help bring the cost down for next year.
Thanks, Pam, and we'll also look to provide a little more detail on some upcoming finance committees as well. But I just wanted to share at a really high level some of the broad buckets of work streams we have running currently to try to address some of the shortfall that we've seen really over the past probably 18 months or so. The first is on the revenue side. There's sort of a series of conversations or issues that we've raised with the state that relate to different components of how our rates are built up and or how the risk adjustment process that the state evaluates is working and may have some potential gaps given some of the uniqueness of our plan compared to some of the other more national for-profit MCOs. So that's kind of broad bucket one. And then more specifically on the cost side, we've been going through a series over this past quarter of different contract renegotiations that ranges pretty much the gamut from each of our administrative contracts to a variety of our different value-based care contracts that we have with providers. And so that's a bucket. Then we're also looking at a high level across a lot of the different value-added benefits that we offer out today to our membership. A lot of those are geared towards various quality initiatives or things that try to incentivize healthy behaviors for our members. So we're trying to do that evaluation in a very thoughtful way that doesn't impact some of the key drivers of our overall quality scores. But there are areas that we see some opportunities where we've had certain things in place that we may not be seeing the kind of value benefit that we had hoped, and so those are areas that make sense for us to pull back on. And then there's a variety of other things that we can kind of continue to evaluate in terms of our broader benefits that we offer and some of our unique programming that we have. And so those are sort of the big buckets that we're going through different evaluation processes on right now. And again, as Pam mentioned, really trying to ensure that we bring the P&L statement back into alignment as we head into 2026, in particular to make sure as we look forward to 2027, when we know many of the challenges of Medicaid are going to be hitting the health system, that we're positioning county care well to be a tailwind for the system during that period.
Question. Okay, so in order to bring it back into alignment, we can either increase our revenues or we can reduce our costs. So it is your belief that the cost will actually be the key to being able to balance it versus increasing the revenue?
Yeah, I think ideally we'll be able to execute on a combination of both. Of course, on the revenue side, we're somewhat dependent on how the conversation with the state evolves there. But what we can directly control on our side fully is more on the cost side, right? And so I think depending on how some of those components play out on the revenue side will help us determine sort of how aggressive we need to be on some of the cost reduction initiatives. But, you know, I think we're going to be pursuing kind of all options right now until we are able to get a really clear picture of what that looks like.
So, Aaron, I think one of the greatest benefits of the county care has been our opportunity to introduce affordable health care to people who didn't have health care that show up at a facility like ours, which is also, you know, happens to be great for the hospital too, because it reduces our reliance on on delayed payments that we would otherwise get through DISH or something like that. You know, obviously the network's designed to, it's bigger than just Stroger and its campuses. People can use providers other places. And, you know, I'm not suggesting that you know, this is something just for us here, but what are we doing because I know our, you know, everything is everything's changed in terms of how, you know, people getting into the plan and whatnot, and, you know, your whole environment on recruitment has changed. What are you seeing in terms of what we can do better at in order to make sure we're covering people? Like, if I have my hospital hat on, what can I do to better utilize the network that you're providing to us as a provider? Is that a fair question?
Yeah, definitely. And I think just to take a step back, I think beyond one of the things that we want to evolve a bit here in our financial reporting is also trying to tease out some of those broader impacts between county care and the health system, because that's where a lot of the kind of net benefit happens, right? So there's a pure P&L look at county care and a pure kind of P&L look on the health system side, but that utilization of county care members at CCH drives a significant financial benefit for the overall health system. And so I think that's an important thing to keep in context as we talk about some of the different strategies that we put in place here. And some things that we, you know, levers we may be able to pull may increase reimbursement, for example, to the health system, which may show up as a negative on our county care P&L, but be an overall benefit to the health system across both sides. So,
in theory, Dr. Mikaitis and I had sidebars about this, and talked about this with Pam. In theory, if we're over budget because we have more members, we should also be realizing the claims, the reimbursements should be lining up, and, you know, with the administrative fees and everything else that we can get for that, it should be a net positive, even though that's taking the hospital as a provider out of it. The hospital being a provider and signing more people up and getting more people covered is that's like hitting the nitrous button in an old hot rod, right? Now you're I can't believe I just went to a car analogy. It's better than football. So, you know, that's the framework I'm thinking, because I don't care about being over budget on expenses if we're also exceeding budget on revenue, right?
Yep. Yeah, and so back to your original question, I think there's a lot of ways that we can better kind of integrate the two systems. We're looking a lot right now at mail order pharmacy, for example, that CCH offers, and ways to expand that offering to our county care members to increase more utilization through that mechanism. The health system is is really uniquely positioned in terms of the amount of specialty care they offer out, particularly to Medicaid populations, which is hard in a number of different areas to get access to specialty care within Medicaid populations. So there's opportunities across a few different areas there that we're trying to look at as well. But, you know, I think the other thing is coverage. So we do a lot of work to enroll individuals, keep them on Medicaid, and we also approach that work, I would say, differently than maybe a typical health plan. Most health plans aren't trying to enroll people out of the jail, for example, or directly in the hospital, inpatient, and emergency rooms. Those are all things that, as a typical health plan, you would look at as likely attracting, you know, what you would refer to as negative risk, likely higher cost individuals. But those are populations that are core to who we serve as county care and as a health system, and to your point, are also populations that the health system is serving, and so are opportunities for us to enroll them in coverage, ensure that they're getting the right transitions back to the community, but also getting CCH reimbursed for that care.
This is going to seem like a strange question, but because I'm thinking of something outside of specific to county care. But our pharmacy, are we authorized to do mail order into any of our neighboring states? So we have DEA numbers for like Indiana and Wisconsin. Okay. Because there's other things that you can do as a pharmacy. We have a great pharmacy operation. We have infrastructure. You know, there's a whole other realm of a business line where hospital pharmacies partner with sort of like cafeteria specialty drug plans where they buy in bulk from like Canada, and they work with a local pharmacy in the state to provide drugs that have bulk pricing that's usually below like what Caremark and other folks do. So just something that popped into my head a little bit. I wear a lot of different healthcare hats, so anyway, sorry.
So I have a couple questions. What are we doing to address the work requirements for Medicaid recipients? That's one question. And then the second question is, are we having conversations with the General Assembly about redefining charity care? I certainly believe personally we need to.
So from the provider side, currently we're just talking with the state as far as what those requirements might be for work requirements. They don't come into play until 2027, but getting ready for that, right? What will be the submission requirements for folks? What proof of employment? How will that work? Will they upload, you know, W-2s, et cetera, and, you know, the system capabilities, so that we don't know what that'll be, what those parameters will be yet. We're just in discussions to do that. That's the work that's being done there. I'm sorry, what was the second part?
Charity care. Are we having discussions about that?
So that, I mean, that has been something that has been talked about for years, even prior to my time. I don't think last I heard, there's an appetite to mandate anything along those lines, but we continuously, you know, float the idea whenever we can.
Thank you.
Anything to add? Yeah.
Nope.
All right. Any other questions on this letter on county care?
A couple questions. This is a question I had earlier, Pam. If we look at the revenue for Cook County Health, what would we say are the biggest drivers of revenue? So let's remove county care, but just county care health. What aspects do we make our most money off of?
So looking to the payer mix, right, which is gross revenue, but you can see what makes up the categories of our revenues. And the biggest is, of course, Medicaid. So it's Medicaid, and it's the supplemental payments that go along with Medicaid that make up the bulk of our revenue.
Define supplemental for me.
DISH, BIPA, directed payments.
Okay, so DISH is what Aaron made reference to.
I made reference.
Oh, you made reference.
Yeah.
I'm sorry.
Yeah. So those are all supplemental payments that basically bring a fee-for-service payment up to a Medicare rate. And those are various, tools, I would say, that the state has to do that. So they can draw down money from the feds to bring up our payments to equivalent of a Medicare payment.
So basically, if you have uncompensated or charity care or something like that, that in this fiscal year, you're taking as a loss, you can apply for a dish payment, which is sort of like
It's just an add-on to our claims pay, yeah.
It's like a Medicaid cleanup payment, but you don't get it, the way the supplement operates, you don't get it in the fiscal year in which you incur the charge. So you have to float the loss, like
2 years.
2 years. And
Now, directed payments are also a mechanism, which those are a 6-month look back on claims. So that one's a little more real time, but that one, there's also a lag.
at a time when we had when our pre-county care, while we were getting county care up and running, and pre-COVID, when the rules were sort of opened up, and it was much more beneficial to people signing up for AS. It was easier to sign people up and maintain them in the network. Our charity care and uncompensated care dropped by a lot, and our reliance on DISH went away. So we had it sort of built in as a factor that we were going to take a loss in a year, and after a while, it sort of gets normalized, because what you're losing that year, you're getting repayment for something you lost 2 years ago. Now that we've been out of that environment, we're going to have to float those first 2 years in order to then get that payment on something that may go away.
Right.
Because there's no, DISH may, as they start cutting Medicaid, a place that's easy for them to cut, and by them, I mean the administration and those in power in Congress would be to eliminate the program and cut off any pressure to reinstitute it. And I don't know if DISH is funded through statute, or whether that's just an administratively structured program that's in the discretion of HHS. But it may have its own separate line item under the appropriation, but it's a place where they could easily cleave it. And no one would understand what it is. That's the thing. That the general public wouldn't understand what it is. I mean, I'm explaining it to people who probably haven't gotten it. I'm a layman who's learned it over years in my role working here on this board and representing healthcare unions.
Here's a question, ma'am. What is the financial incentive for providing, financial incentive for providing service to individuals who do not have insurance?
Is that a trick question?
No, it's not. It's an interesting question, but not a trick.
Yeah, of course, that's not our mission, right? So,
The thing is, we don't do it because of,
I recognize that. I want to
answer
that question.
yeah, but there is no financial.
right. Thank you for saying that. I was not going to do that.
So it's mission aligned. Ma'am, it seems like it's a surface question, but it's not. It's a deeper question, because what I'm trying to get to, and I don't know the answer, that's why I'm asking the question, is if we understand the payment structure for the uncompensated care, then we can start to understand how can we lift it up. That's why I'm asking the question.
So that's been the challenge. If there is no payment structure, we're at full risk when someone comes to us uninsured. It just goes to charity care, essentially, right? It's mission aligned, right? It's what we do. But that's why we've been trying to tighten up operations and ensure that we're thinking from a population health standpoint, because much like the birthday health screening, right? If we're catching cancer early, we're not having people come with advanced prostate cancer to the emergency department that we're still going to have to treat, right? So much
I
more
meant my
expensive.
answer, I meant my answer to that, because it is, it's a population health issue.
Right. So instead of having advanced uncontrolled, advanced prostate cancer uncontrolled pain coming into the emergency department, we're screening and catching it early, right? So we're avoiding that downstream cost that's more costly to us, it's more costly to the patient and the community that they're from, right? So.
That's right. That part I understand, that's the business I'm in, but the question is, if a individual comes in, how do you get money?
Sure. I mean, we have financial counselors that run through everything that's available for them, including charity care. But again, depending to Dr. Makaitis' point, depending what's wrong with them, right? If care is not emergent, we can make a repayment arrangement, right? So, but,
We sign them up for county care too.
Yeah, and county care.
We have navigators.
But again, that goes back to the difference between charity care and bad debt, right? Charity care are those who can't pay, and bad debt are the ones that won't, but could, right? So.
Because we have people who aren't covered, but
Means, yeah.
Yeah, they have means. They don't have insurance, but they don't qualify,
Right,
for
and we may
Medicaid.
see that more, right, if with the commercial, the ACA subsidy, cuts, right, we may have people forego buying insurance on the exchange because now
Oh,
the
we definitely are.
pocket is gonna be too much,
That was
right?
on the NPR as I was driving in this morning.
Yep, and so now those people may wind up coming to us, where before they were going to Rush or UFC or anywhere because they had insurance, and now maybe if Rush, and to, Commissioner Lowry's point, if they do their fair share and continue to see them as a patient, as a charity patient, great. But if they say, no, we've hit our max and you need to go over to county, then we're gonna see.
Because the reality is, the way healthcare is designed in this country, that unless you start out with the job that provides healthcare when you're young, you get into the young invincible, mindset. It's also the people who have a choice between a PPO and an HMO, and what level of care they want to do if they have health provided. And, people have also figured out the biggest scam we have is that, most healthcare, go back to the 50s, the premiums were 100% covered by the employers, and employers decided that they wanted to be able to say that they gave 3% increases, or 4% increases, or 5% increases, but they did that while they were also increasing the amount that someone paid for their health care. So the 3 or 4% increases have a net pocketbook effect of less than that number. So people sometimes forego even signing up for the health plan when it's available to them because it hits they'd rather take it in their pocket. And the young invincibles grow up to being people who need health care, because we all need health. We all need health care at every point of our life, but you certainly need it once you get past a certain age. And now, the ACA allowed us to fight back against the young invincible mindset. So people tell me, my friends in the nursing union tell me single payer is the answer.
I don't know what NPR
Yeah.
said, but our current estimate is 35% of ACA adults won't continue their coverage because of the increased out-of-pocket costs.
They even dropped the number of 350,000 statewide. But,
Yeah, I'm not sure where that, but yeah, it's a big number either way.
Yeah, I want to provide a different context, picking up on what Chair Ryder said about the young invincibles. When I was working at the health department in the 80s, I was managing a citywide program focused on blood pressure control, and had the opportunity to work with Dr. Frank Douglas, who at that time was over the hypertension clinic at the University of Chicago. He's a cardiologist. He actually went to pharma from there and moved to Switzerland. But one of the things he said when we were talking about blood pressure, because in hypertension, they call it an asymptomatic disease, because there are no symptoms related to an elevated blood pressure. People feel fine, but they don't know their blood pressure is elevated. But he said, and he claimed that there were 3 symptoms of high blood pressure, hypertension: heart attack, stroke, and kidney failure. So that's what we're seeing, an increase in that, because people have not gotten health care, routine screenings, whatever, when they were younger, between 20, 50 to 60 years old. They stay away from health care. Then all of a sudden there's a critical issue that comes up. Then they come in. so the more we can do to get people to use routine care, hopefully we can get some of those numbers down. And we're also living
I'll give you
longer,
a
too.
fourth one to add in, since you're throwing things in there. This one's not necessarily scientifically backed yet, but watch the metric.
That's on the increase, too. But we're living longer.
See, don't you see?
Well, and that's also why, Joe, the importance of health departments doing things like, promoting nutrition and,
Right.
you know, bucking against the standard American diet.
Yep.
And violence prevention programs, because all those things play into health outcomes, right? So,
You know, the other thing, we focus on the health system, obviously, here in this space. But in Cook County, we need a healthier population. We need people who can work. We need people who can own property. I mean, all of this has to be looked at big picture, even though our focus is the health system.
Now, Commissioner Lara, that was loaded. That was really loaded. And I have a tremendous number of thoughts on that, because now we go into legislation. And, yeah.
So we're working in that space. You know, we're through NACO. President Franklin pulled together a group. We've met with Hennepin County, Harris County. We have a follow-on in December with them. We're thinking at NACO, we're planning to in February at NACO's national meeting to...
What is NACO?
NACO is the
National Association of Counties.
And for reference, what
you asked the
I...
question, you knew the answer.
What, yeah.
But in late people
I appreciate the prompt. You know, what I thought was interesting when you look at the numbers, red states and counties will actually be more deeply impacted by the Medicaid cuts than blue states and counties. So one of the kind of discussion points there within that group was, how do we figure out a way to find that alignment, and how are we engaging the right people through the right lenses, our labor partners, business community. I'm actually heading over to the commercial club to talk to kind of the business sector later today about here's the implications with these Medicaid cuts and how it's going to impact everybody. So we're working to build that coalition so that everybody really understands through their own lens why this is important, and beyond that, then pulling that group together to how do we better communicate, how do we advocate, and then how do we start pushing for better legislation. So, I mean, I completely agree.
Yeah, there's going to be a lot of policy opportunities. We're not going to go pass a bill in the short term, but the Trump administration is creating a healthcare crisis.
Yep.
that is going to be at their door, and certainly by the time we have our next presidential election. Problem is that's too long to wait. And I think what we just saw with the government shutdown, normally in a government shutdown, regardless of usually the party in power doesn't take the hits like the minority party that is holding votes off of on a filibuster. But this time, the people who are responsible actually took the political hit on it. It's always the party in power, because the party, the filibusters meant to force a bipartisan agreement, and that's not what we ended up with. But the discussion this was all elevated to a point where now it was we know who wanted to push off talking about health care, and we're gonna see and as that's happening, as it's one of the top issues, you're hearing about all this on NPR. Everyone's gonna see it in their mailbox, right, through increased premiums, and it's gonna if it doesn't force a discussion, then shame on all of us, not all of us here in this room, but all of us as a country now recognizing the explosion, because it's going to hit everybody.
So I'm interested in seeing kind of what kind of fallouts, right? Because there are different ones that I think right now an option. We I don't know if we thought about this. I know in 2021, I think the county launched a food is medicine program, and I think I just saw that that program is still active. However, if we can increase the amount of people who know it and can access it and have the knowledge, as well as partnering with different organizations that provide, like, grow bags, things like that. It sounds, I'm family medicine, it sounds cushy, but that kind of knowledge for people actually historically has been shown to present them with alternatives to kind of what may be available in the neighborhood that contributes then to hypertension, diabetes, those type of things. And the more people that have those tools, because it takes us as humans a while to make that switch. So we may be kind of at the tail end, but there's still opportunity, I think, to grow that heavier, in a heavier way and make those resources kind of available. Those are the preventive, the things that you can prevent, the preventive things. Now, there's also, history shows there are also things that may not be preventable, like, virions and things like that may spread because of kind of what's going on. And also that's where incident command comes in and beefing up on that. But certain things that are preventable, I wonder, we already have the tools at county. I think I saw a post about food as medicine and nutrition services, and if you look historically, that can play a very pivotal role in saving off some of the stuff that may be coming down the pike for some people because of the federal changes. So.
Well, food as medicine was started by, was championed by our late colleague, Commissioner Dr. Dennis Deere,
yep.
who really, and I know that there's been a commitment from myself and Bill to make sure that program stands up, stays, and is robust. Also because I've seen that in my own life, right? When I switched to a whole food diet, I cut out red meat and pork, which cause, when they digest, they create toxins that promote the hardening of our, I turned 49 years old, I got a heart scan because of my elevated cholesterol, and I learned a lot. I went and got a heart scan. Most people don't get a heart scan. My calcium score, my heart scan was 131. And any of our doctors in the room, that's not where you want to be at 49 years old, right?
That's not where you want to be at.
No.
I'm sorry. What's happening in my head?
You don't want to be there. And I ate a relatively, what I thought was a healthy diet. There's two things that help people. Exercise, which I have a struggle with my job, and the other thing is food, is job and my family. But it's food, whole food, things like that, and they can make a difference. It lowers, changing your diet, just changing from white pasta, whole grain pasta, can help you lower your blood pressure, right? Cutting down your saturated fats, help you lower your blood pressure. There's other things, and those are the things that we can help, that the county health department can do, that we can help support here on the health system side, and they're important, and they are ways to help drive that population health results that Dr. Makaitis was talking about earlier.
And I see people looking. This is finance. This is going to reduce the burden of cost. Going forward. So it is a very integral part. It may sound off, but it's right where it needs to be.
We're not off topic at all.
Yep.
Here's a question, staying on the topic of food as medicine.
We do have to eventually move to the rest of the slides, but yes, it's not to cut you off. Go ahead.
Okay. Is it possible to incorporate that into county care in a way that draws so many people to want to participate with that plan in particular? Then it ties into Cook County Health. So basically, I'm trying to find a way to do good and monetize it such that it actually builds a system up that becomes self-sustaining. The idea being that it is the attraction to make people want to come to Cook County Health. It is the attraction to make people want to come to Cook County Health Care, because no one else is offering in that format. Because there are a lot of people that have some knowledge about I should eat healthier. The question is how. You know, we hear about food deserts. We hear about all this stuff, and no one has an answer to it. But yet, Cook County Health and Cook County Care serves that population day in and day out, year after year. So if we take that, and this goes back to the question I was asking Pam, if we can find something that actually will pull in the people to want to be in our revenue stream, not just in our cost stream.
So I'm going to ask, I think this question is actually probably better for Aaron. I'm going to ask this question, and then we're going to need to move on to the next slide. Aaron, what type of, in our health plan, what type of supplemental resources do we provide our members, you know, like other health plans do? Do we, you know, for wellness? This is part of like the wellness portion of a health plan. I would assume that we have wellness tools that are incorporated.
Yeah, that's correct. And we offer a pretty expanded area of benefits around this, and this ranges from things like member incentives for doing things like preventive activities to, you know, we have what we call our food care program, which includes an expanded benefit beyond what basic Medicaid covers for things like visits to a nutritionist. We do an emergency meals program for certain populations, and then we also have a medically tailored meals program that can help support individuals with specific diagnoses. You know, I think, so we have a broad suite across those programs, and I think one of the challenges is that those are all long-term benefits,
for sure.
right? So we're investing heavily in those preventive activities. But the funding mechanisms for things like our rates for county care are done on an annual basis, looking at cost from the year before. So that's one of the challenges as we have to go forward and make some of these decisions around the programs we offer, and you know, how do we right-size our financials? Is how much do we invest in that prevention?
Well, yeah, and because the wellness, there's a real-time cost on our wellness programs, but it's a long-term result. But I think it's helpful for context, maybe at the next board meeting. You know, not everybody goes to every committee. I'm sure that so outside of the managed care committee, if there's something you could walk us through, like the experience of a member that will show us, you know, the wellness-related items and the things that you offer in terms of long-term care that also could be at risk in the current financial environment, but are long-term investments that can help improve the population health.
Yeah, absolutely.
All right. Okay. Meeting's back to you, Pam.
I'm finished.
All right, great. All right, good.
Can I make a statement?
Sure.
Oh, it's an observation. 20 years ago, and it might have been more than that, the American Cancer Society, the American Heart Association, and the American Diabetes Association got together and established a program they called Everyday Choices. It's simple. The choices we make every day contribute to our health. And so what we need to do is to get people, the population at large, to make better decisions moving forward. And I think that's what we're talking about.
Yeah,
that's what public health does.
And here in the United States, it's incredibly difficult because like right now, one of the trends is to start restaurants frying foods in beef tallow because there's an incidental benefit from beef tallow that is not offset by for people that intake straight saturated fats that could increase their arterial plaque. But we have a bizarre culture when it comes to mass consumption of things that are toxins. By the way, we could all skip you're coming to the table. All right.
You want
us
to go sit back down?
Yeah, no. This is my favorite part of the program.
I can tell.
Our agency reduction plan, presented by Whit Buren, our Chief Human Resources Officer. Officer, and Craig Williams, our Executive Chief Operating Officer. All right. Gentlemen?
Good morning. All right, so during the past 11 months, we've made significant progress in hiring. Highlighting right now, year-to-date, we've made over 1,800 offers. Of those, 1,282 are accepted, which provided us with a 70% offer acceptance rate. We filled 1,233 positions, which is up 179 year-over-year. Separations remain consistent and are actually declining slightly. Net new hire activity, we're consistently bringing in more new employees than we're losing. Last year at this time, we had a net new hire count of 255. This year, we're at 445, so we're seeing a 75% increase in net new hires. Next slide.
This graph analyzes the monthly headcount and percentage of agency staff from September of '24 through September of '25. So we're actually into our second year of tracking these numbers. And you can see our agency staffing continues to trend down, both as a total number and then as a percent of total staff. For September, we're at 770 total agency FTEs, which is just above 10% of our overall workforce. We are down about 40% from our initial point, and, we continue to make progress here. I will say, I start to wonder if we're starting to get to a floor on agency. There's a lot of work happening on the nursing side that I think will start to continue our downward trend, but as you remember last year, we did have a slight uptick in December, so there is some seasonality in these numbers, mostly around ensuring that we have the right staff to care for fluctuations around flu season, but also to deal with retirements, which we know have usually occur at this time of year. Next slide, Debbie.
And usually, when you get into December, holidays and things like that usually drive temporary staffing.
Yeah, so I don't think we'll see the numbers are going to go up, but we'll probably see that report January, February, because we were always trending a little behind. Yeah.
So these metrics show our agency FTE trends overall by job code. You can see that we continue to have reductions across all of our job codes for the most part. This month, we're seeing the highest reduction in clinical nurses, but we continue to see reductions in Core 5s, medical assistants, food service workers, and transporters. And I think this reduction shows reference to converting agency staff to permanent employees. And really, I think, is a tribute to the work of HR being able to convert agency employees to staff, but to continue to bring people in. A couple notes. So there was a blip on the psychiatry APNs at Providence. That's related to our CTSC, so that's why that went up. And then some may note, I'll just try to avoid this question, but we did have a slight uptick in building service workers. We have so we went from 8 in August to 15 in September, kind of right on the middle of that page. We have 173 building service workers overall, so, we basically went from about 6% of our workforce being contract labor to 8.6. So, and when I looked at the report, the most current report, we're already down from 15 to 11. So, we're always going to have some of these, a little bit of noise, I think, in this report, but I did want to at least address that increase month to month. Next slide. The last is our locum tenens utilization. I think for the month of September, we were right at 41 FTEs. We've grown a little bit since we started reporting this data. I think the biggest growth of note on the report is within the cancer center. We did have one of our physicians left last spring, and we've been recruiting additional PAs to sort of offset that loss to ensure that we have access in our cancer center. We continue to reevaluate that, and we'll have a plan going into next year.
I believe Dr. Franco's on the line.
Good morning.
Do I hear something online? I have a question.
Before we get to HECZone, Dr. Green has a question.
Yeah, so earlier we see bringing on the maternal fetal and heme onc physicians. Is that what we saw earlier, or?
You did, in terms of the, emergency contracts that were presented? Yes.
Yeah. So, where would, two things, where,
So, if I'm anticipating your question, what I would say is in maternal fetal medicine, right now, we're not providing the level of services that we need for high-risk moms, and so having the MFM contract will allow us to have physicians that can care for those high-risk moms. We don't have locums in that area right now. And then HEMONC, part of this cancer center increase around the PAs was to deal with deficits in physician staffing, and so, as I said, just reevaluate what we need overall there. That's a piece of that.
okay, so that's where those are.
Yep.
And then MFM is not here.
It's not.
Okay,
It's just a service gap right now.
okay. Thank you.
Thank you.
Dr. Spronka, I believe we're ready for you to go ahead.
Terrific. Good morning. So we continue to report strong progress in the staffing solution. Kind of folks initially started out at Hectone. Over the last year, the vast majority of them kind of made their way over to MedX, and we've been systematically going through the variety of steps to be able to post positions and make offers to eligible staff. So as of the end of October, 37% of those individuals at MedX have successfully transitioned and onboarded at CCH, with about 4% more scheduled for onboarding sometime in November or December. That leaves 59% who are still at MedX. I just checked with my colleagues in HR and finance earlier this week. We are on track to get the vast majority of the remaining folks positions posted, offers made before the end of the year. The progress is going well, and we're excited to see the finish line for this long staff journey by the end of the calendar year. Happy to take any questions.
Any questions?
Thank you, Dr. Sprinka. Just so we can get a, started and how many people are currently in it and how many people have dropped out of the process. So input through output.
Yeah, so there were a small number of people who decided not to transition from Hectone to MedX. It was under 5. They chose to either retire or take different offers somewhere else in the Chicagoland area. Thus far, we've only had one person at MedX decline an offer from CCH. It's continued to be a very kind of a very positive experience for folks. They've hung in there. They're excited to join CCH and continue to perform the work that's funded by these extramural grants.
Thank you so much. I know we had a timeline. Is there a new timeline?
By the end of this calendar year, we expect to have finished posting positions, making offers, and onboarding the majority of the staff remaining at MedX. We may have a few people who, for one reason or another, there's a small detail that's being worked through, who still are at MedX after the end of the calendar year.
Thank you.
Any other questions on Wilkins County or Gonzales Wilkins? All right, great. Thanks, guys. All right. With that, we've exhausted the agenda, so we are adjourned.